is Kevin Henze, and I welcome you to what should be a very exciting and timely discussion on the topic of addictions recovery during COVID-19. As a faculty member in the graduate counseling programs, an admission coordinator for counseling in the Transdisciplinary Addictions Professional Postgraduate Certificate Program at Regis College, I truly look forward to moderating this evening. As we gather virtually, I'm mindful how our lives and routines have been upended by COVID-19. While this upending has impacted all people, tonight we are focusing particularly on the intersections of COVID-19 and people and programs connected to the addiction recovery community. We are honored tonight to be joined by a prestigious panel of speakers. However, before I move into introductions, I need to tend to some housekeeping announcements. First, in order to receive contact hours or course credits, participants must stay to the end, which includes the question and answer period. Second, participants must also submit a completed evaluation at the end of the program to receive contact hours or course credit. Third, if you are not requesting contact hours, we still hope that you will fill out an evaluation form. Your input is very helpful to us in improving our presentations and selecting topics for future panels. Fourth, please note that Regis College expressly prohibits attendees from recording or rebroadcasting this lecture by any audio or video means, and we sincerely appreciate your cooperation with that. And lastly, we have received no commercial support for this evening, but we want to acknowledge the continued generous sponsorship of Harvard Pilgrim Healthcare. So now, let me introduce our panel. Our first speaker will be Jessica Huxley, the founder, CEO, and director of Addiction Policy Forum, which is a diverse partnership of organizations, policymakers, and stakeholders committed to working together to elevate awareness around addiction and to improve national policy through a comprehensive response. Jessica received her Bachelor of Arts from Princeton and is a national expert with more than 25 years in the field of addiction. She has worked with our nation's top scientists to translate the science of addiction into digestible information for patients, families, and other key audiences, including Congress. Given her expertise, policymakers and government officials have called upon her to drive national policy and innovation solutions. In 2017, Jessica testified before the President's Commission on Combating Drug Addiction and the Opioid Crisis, providing recommendations to the committee on how best to implement a comprehensive response to address the opioid crisis. Jessica has also testified before the U.S. Senate Committee on Health and Education, Labor, and Pensions, and the U.S. House of Representatives Committee on Energy and Commerce, Subcommittee on Health in 2018 on critical provisions that were ultimately included in their historic Support for Patients and Communities Act. Prior to that, Jessica worked on the passage of the Comprehensive Addiction and Recovery Act, the Second Chance Act, and the Drug-Free Communities Act, to name just a few. She currently serves on the board of directors for the DEA Educational Foundation and was recently appointed to sit on Ohio Governor Mike DeWine's newly created Recovery Ohio Advisory Council. Jessica has conducted numerous CME trainings for medical professionals and other key stakeholder groups. And tonight, she will provide the context of our presentation as she focuses on the impact of COVID-19 on patients, families, and individuals in recovery from substance use disorders. Our second speaker will be Kristen Nolan. Senior Vice President of Behavioral Health Services, Spectrum Health Services. Spectrum Health Services is a private, not-for-profit substance abuse and mental health treatment provider based in Worcester, Massachusetts. Kristen brings over 20 years of diverse experience to her presentation this evening, having begun her career with Spectrum as a substance abuse counselor in 2000. In 2005, she was quickly promoted to program director, where she oversaw Spectrum's largest outpatient treatment center on Lincoln Street in Worcester, Massachusetts. She was promoted again in 2007 to director of outpatient services, where she was responsible for the operation of all outpatient clinics. Ms. Nolan has also overseen Spectrum's out-of-state expansion and continued outpatient growth in Massachusetts. Named one of Worcester Business Journal's 40 Under 40 honorees in 2010, Ms. Nolan has a master's degree in counseling psychology from Anna Maria College and her bachelor's science degree in social sciences from Southern New Hampshire University. Tonight, Kristen will be speaking on maintaining care access and operations for addiction services during COVID-19. Our third speaker tonight is Dr. Sarah Bagley. Dr. Bagley is a primary care physician at Boston Medical Center, a graduate of Georgetown University School of Medicine, the combined internal medicine and pediatric residency at Brown University, and the Boston University Addiction Medicine Fellowship. Her particular research interests are in the treatment of opioid use disorders in the adolescent and young adult population and the involvement of the family in addiction care. She sees patients in both general internal medicine and the Adolescent Center. She is the medical director of the Catalyst Clinic, a clinical program to provide integrated medical and behavioral health care for adolescents and young adults who use substances, and an attending on the patient addiction consult service. Dr. Bagley is an active researcher who has several ongoing federally funded projects related to addiction and recovery. Tonight, she will be addressing the topic, treatment from a distance, the transformation of office-based addiction treatment. Our fourth and final speaker this evening is Warren Nicholay, Director of Bay State Community Services Recovery Center in Quincy, Massachusetts, otherwise known as a New Way Recovery Center.
Can you help me get on this?
It is funded by the Department of Public Health, Bureau of Substance Abuse Services, and is part of the Massachusetts Peer Participatory Process Model, which is proudly hosted by Bay State Community Service. Warren Nicholay is also a peer counselor. This peer model connects individuals in recovery and ensures that communities make their own decisions in providing support, resources, and encouragement for all paths of recovery. The center's staff, all who have lived experience, offer support no matter what recovery pathway is best for each individual. The staff welcome all who seek a safe and supportive environment and offers access to community connections, educational resources, sober activities, and much more. The lives of everyone who are affiliated with the center have been touched in some way by substance use. Together, members of the center are committed to sharing these experiences in order to build a strong, safe, and reliable recovery community. Mr. Warren will be presenting on sustaining recovery and mutual support during COVID-19, a recovery culture's role. And now, I would like to hand it over to our first presenter, Jessica Holsley.
Thank you so much, Kevin.
And just as so all the presenters know, I am happy to advance your slides as you wish. Simply let me know.
Great, great. having a bit of technical difficulties tonight. So is the camera and everything working on the iPad?
It is perfectly centered.
Wonderful, wonderful. Well, thank you so much for having me tonight. I'm so delighted to join you all and to talk about this really important topic. My name is Jessica Henze. I started the Addiction Policy Forum. We bring together patients and families, experts in all the different key components of a comprehensive response to improve outcomes and bridge the gap between research and the patient community. We work to end stigma. We've been around since 2015, so a relatively new organization, but I've been doing this work for a little bit longer than that. So tonight I wanted to share with you a little bit on a study that we conducted earlier this year to really understand the impact that COVID-19, the pandemic, has had on our patients, families, and individuals within our community struggling with substance use disorders. So next slide. So we conducted a study. We had 1,079 respondents from 46 of 50 states, so pretty broad reach. And we really tried to make sure that we brought in a wide array of individuals on the patient side, both with an active use disorder, individuals receiving treatment, and individuals in recovery. And then we also had a number of caregivers and family members who participated. We made sure that everyone was over the age of 18, and we also had only 2 weeks to recruit. So it was a relatively rapid cycle study to make sure that early in the pandemic in April, we were able to really provide some feedback. The study was funded by the National Institute on Drug Abuse at NIH, NIDA, and wanted to make sure that researchers there and leadership were sort of hearing from our community as quickly as we could sort of put this together and really start to provide that input. As I mentioned, broad array of individuals. People could select multiple categories, but we had a 54% from who identified as in recovery, 40% who were family members, 11% currently using substances, and 8% in treatment. Next slide. The other things I just wanted to point out from our community, and then we'll get into sort of the impact of COVID, is 2 out of 3 of our respondents struggle with poly drug use. And we've had a few surveys and outreach that we've done since then. This is very consistent. Our community doesn't struggle with a single substance of concern, and that's sort of, it changes, and there's some variance by age or region, but really it's about polysubstance use that we're struggling with. In terms of the primary substance that people are focused on or share with us as their main struggle, the majority is still alcohol use disorder. Next slide. Now, when it came to sort of the impact of the pandemic on recovery, we had 1 in 3 respondents or participants share with us that they had disruptions in their treatment and recovery services. They weren't able to get recovery services. Biggest sort of write-in response was real concerns about recovery support meetings, mutual aid support meetings being closed down or unable to access, and not quite the same experience using Zoom and other technology-based support group formats. Confidentiality, missing that pro-social engagement. There were Zoom bombers and some real disruptions early on that made this very difficult for some individuals. Now, we did have some who reported they were receiving telehealth treatment. They were getting medication either curbside or getting things delivered. They were able to access take-home medications, but the broad majority, and especially doing follow-up qualitative interviews, was really real difficulty in the disruptions of the routines and the components of their recovery support that were really necessary. In terms of the sort of testing, we had most of our participants in our community hadn't ever experienced any testing or symptoms of COVID, and a few had, yet did not access healthcare and shared concerns about stigma and how they would be treated in the healthcare system, so sort of went it alone. In terms of concerns that were expressed by our respondents, becoming infected. This, sort of very consistent with what the general public was feeling. Becoming infected, spreading, the social isolation, loss of job and loss of income. But the emotional changes, worry, sadness, fear, and loneliness, really sort of consistent across all of our folks that were responding to this. Next slide. The other thing I wanted to sort of speak about, so we did have 4% reported overdoses since the pandemic began. And mind you, this is a April 27th through very early May. So there's been several months since then, but we had 20% of our participants report increased substance use since the pandemic began, and 4% reported overdoses, including several fatal overdoses. This was sort of an early warning to what we've heard from many jurisdictions and public health officials of increases in both relapses and overdoses during COVID-19 pandemic for a lot of these reasons you're hearing about: isolation, loneliness, uncertainty, disruption in services and recovery support. The other thing I wanted to mention that we found is that there's a perception that amount of time in recovery is protective, right? So when we have some of our community writing to us or doing an interview with us saying, I've had 11 years, this shouldn't be so hard. I've had 19 years and this is the first slip I've had in that entire 19 years. I think that we didn't fully understand what the impact on the mental health and the substance use disorder disruption would have on our community. And we know this from, recovery support basic tenets that are you hungry, tired, lonely, bored, as being sort of triggers or things to be mindful of when you're managing your recovery. And most of the country has been lonely, tired, bored, maybe not hungry, but those three at a pretty significant percentage of time over this year and in the course of this year. So helping our community manage that, I think, has been something that we have focused on at Addiction Policy Forum, knowing that looking at our overdoses increase, looking at relapses that are reported, looking at increased use reported across the platform of both individuals recovery currently using and caregivers, really gives us pause. The next slide. I also wanted to share just some of the comments and the quotes from our community. Not being able to be active in meetings has been disappointing, right? So many people dying of overdoses. I started using again. A mom writing in worry about her daughter and how this is affecting her recovery. And I think I have another page of these. So next slide. No, I missed it. So one of the quotes that really stuck with me when we were doing interviews is one individual wrote to us that I find it so disappointing that liquor stores and weed shops are open, but my treatment and recovery support is closed down. This society is so twisted. And that really stuck with me. So we've communicated with different states that should there be, hopefully there's not, this doesn't continue forever, but should there be another lockdown, for example, should we hit these strange circumstances again, to be really mindful of how important recovery supports are for this community, who are both vulnerable to COVID-19 because of lung and heart impact, but also very vulnerable to some of the disruptions in the services and the supports that are needed to manage their long-term chronic health condition. So it's something we've really focused on. Next slide. So just a couple key takeaways. As I mentioned, more overdoses, including fatalities. We've also seen increase in fentanyl in our supply just because of availability in many parts of the country, which is even more concerning. We have 1 in 3 reporting disruptions in their treatment and recovery support, and more individuals, regardless of length of time in recovery, requiring those supports during such a stressful time. And the thing we try to stress with some of our community, and we're trying to explain this, is coping mechanisms and how we build healthy coping mechanisms when we are struggling with substance use disorder is really an important component of how you you build your plan, right? How you prepare for your triggers, how you prepare for life, and sort of the everyday difficulties that can sort of make you slip up and be difficult in your path. This year, looking at how much stress and anxiety all of this has meant, from political unrest to issues at home, to the pandemic and health concerns and a pretty scary virus. All of that sort of compounding, I think, has made us look at how we can work with our community to really shore up what our coping mechanisms, what our telehealth support, what digital therapeutics we can use, because when the components that we rely upon, whether it's I do yoga 2 times a week, I'm a avid gym goer, I do AA or NA or Celebrate Recovery or Refuge or Heroin Anonymous or the other 30 different brands there are of support group meetings. These are so necessary and fundamental to how so many individuals map out and take care of themselves and are part of their chronic care plan. Any disruptions to that can be really dangerous and worrisome. Other things is sort of focusing on how we can provide more resources and know what works and what doesn't. There's things that have changed because of the pandemic that are hopeful and helpful. We have easier ways to access MAT than we saw previously. DEA has been very cooperative in changing some of the MAT rules and regulations. We have more telehealth. We have more digital therapeutics that are being used. So there are lots of new tools in the toolbox that we might want to continue. But we've also learned things that have not worked as well, right? Zoom meetings work for some and they don't work for others. So making sure that we learn those lessons and we listen to our patients and families about what the true experiences and the consequences and the effects of these changes have had on their substance use disorder and their recovery is really something that we're focused on and we take seriously. Next slide. Need for more research. We're working on a piece right now to sort of understand vaccine readiness and how we can share information with our community, when a vaccine is ready and available for individuals here in the US. Other things, what are the overall effects of isolation? What are the effects of the changes in service and the modifications? All these things that I think we want to make sure that we're engaging the patient community in research so we can have rapid feedback cycles to let sort of the powers that be know what's happening on the ground. Next slide. Very briefly, our demographics, largely white sample. Also have a lot of still concerns about participating in research from our African-American population with an SUD, as well as caregivers. So we are listening on how to bridge that gap and make sure that we have a more diverse pool. We had a largely over 40 female population. This is a little bit more diverse in our second study. And we were able to have a pretty broad cross-section of states that participated. Next slide. So that's the next person's slide. So just sort of a few wrap up points. We're excited at Addiction Policy Forum to make sure that our community is participating in research so that we can be at the table and have quicker ways to have those cycles. The only way we're really going to see major advancements is by participating and linking to science. And we want more medications and better treatments. And we want to close the gap between what we know works and what the family community and the patient community understands. There's still far too much misinformation and stigma that exists, and far too long of a gap in having new knowledge and making sure it gets into the hands of those who need it the most. So that's something that we're really focused on. And I think there's still a bit of a long haul in how we are responding to the pandemic. And individuals with substance use disorder, and sort of looking at this as a condition that makes you a little bit more vulnerable to COVID-19, according to NIH, but also makes you more vulnerable to isolation and changes to your daily life and anxiety, makes this, in our opinion, a really important priority population to focus on.
Thank you so much, Jessica. I'd like to now hand it over to Kristen Nolan. Kristen.
Thank you, Kevin. I just want to start out by also thanking Regis College for the invitation and the opportunity to speak tonight. So I think this pandemic has been challenging, obviously, for all healthcare providers, but in particular, I think it's been a challenge for addiction, substance abuse treatment providers, because we're also dealing with a simultaneous public health crisis, which is the opioid epidemic. From my perspective, over the last 8 months, we've only seen an increase in the demand for these services. And so it's certainly been challenging. I just wanted to start out giving a quick overview of Spectrum and our model of care, so that people can understand the perspective that I'm coming from with this presentation. We're a very large organization that spans across 5 states and has 1,500 employees, but tonight I'll focus on our behavioral health services just provided in Massachusetts. On a side note, all of the photos that you see in this presentation have been taken of our staff or of certain instances over the last 8 months. And we actually did a collaboration of these photos and sent it out as a staff appreciation video via email. But Spectrum's model of care is really based on the belief that the longer we can keep someone engaged in treatment, the more successful they'll be in their recovery process and their own personal recovery journey. We have 3 levels of care in our inpatient services. One is ATS, which is commonly referred to as detox, clinical stabilization services, which is referred to as CSS, and then long-term residential care. These beds total 269. We have 2 campuses, one in Westboro and one in Weymouth. And then we also have 15 community programs spread across the state. Those programs provide MOUD, medication for opiate use disorder, regular substance abuse counseling, groups, intensive outpatient programming. So the idea of this is to really, hopefully admit someone into detox, let them go across our continuum of care and inpatient, and then after they complete residential programming, to step down into those community-based settings. So next slide, please. So like everyone else in March, we were faced with the grueling challenges. And from my perspective, it was really 1 week we were okay, and the next week things really got very interesting, to say the least. We had to come up with new ways to do things really quickly. And so we met as a staff team, as a leadership team, and really tried to think, okay, what do we need to do first? Next slide, please. So the first thing we did was we created a centralized intake point for all of our programs. In Westboro, we did this by placing this beautiful temporary trailer in the parking lot of our largest detox unit. And then in Weymouth, we kind of did a tent version of this because we didn't have the same kind of space. But in this was the point of entry to all of our treatment programs, all of our units. And when you came, when you presented for treatment, you had a temperature check, and then you did a quick COVID questionnaire. And then, once you cleared the trailer, so to speak, you were able to go and finish your admission in the program in which you were admitting. I think, our number one priority quickly had to become the safety and the health and safety of staff. And, us, along with everybody else, really struggled for PPE. And, I think that I'll be ordering PPE for the next 10 years just to make sure and stash it somewhere, because initially it was so hard to find. We ended up getting a lot of our initial PPE from China, but once we found it and we knew it was out there, we were able to get it pretty quickly. And then, we let staff we set the standard for the lowest threshold for PPE, but then we gave staff the option if they wanted to do more so they could feel safer. They had the opportunity to do so. So next slide. So this picture really, this happened right outside my office, and this was really a sign to me that things were rapidly changing when this truck pulled up to deliver us PPE. We were so fortunate to be able to access the resources of the National Guard, and they came to campus several times to deliver the things that we had asked for. So we did have to purchase a lot of PPE, but we also were really grateful for the state for making some of the things that we needed available. Next slide, please. So prior to the pandemic, we had 4 cafeterias that spread across our 2 locations, and meals were served in a buffet, serve yourself style. And I mention this because I think it's such a significant thing. I mean, to go from a buffet style 3 times a day to pre-packaging 3 meals a day for 269 beds is a pretty big feat, and we did it very quickly. We made this change very quickly. We were turning over 800 prepackaged meals a day, and what we did is we instead of using the cafeterias, we kept all the units split up in the interest of safety, and so we were delivering meals to 10 different units. So 800 meals to 10 different units. Going from just a buffet style is such a significant change. And as you can see, they did a pretty nice job. That food looks pretty good. That wasn't without some bumps in the road, though, certainly. So what do you do with a positive case? You might have a staff come back. You might, have a client that leaves treatment and then we're notified that they tested positive. And, we made a decision really early on to make sure we were transparent with everyone, our staff and our patients on the units. And so as soon as we found out that there was a positive case, we shared that information. We became very good friends with the Board of Health people in our towns that we provide services. We deep clean units, and we constantly look for ways on how we could improve what we were doing. I think it's important to mention we never closed a unit. If we had a positive case in a unit, we stopped admitting to that unit, and we offered the folks that were there the opportunity to quarantine for 14 days. That was initially, we didn't have the testing capacity that we have now, but initially, they were offered the opportunity to quarantine. And for the most part, insurance companies were okay with this. They wanted, these patients to be safe, and but Spectrum felt like it was the right thing to do, and we all felt like it was the right thing to do to offer these folks a place while they were quarantined, a safe place. Next slide. So, telemedicine, a lot of folks are going to talk about that tonight, so I don't want to get too far into it, but we were challenged with how do we provide the clinical component of the care on the units. And the Bureau of Substance Addiction Services, offered waivers for the minimum requirements, and did different things to make it doable for us, but it still was challenging. And we utilized telehealth very early on, particularly for our physicians, our psychiatrists, to be able to connect with these patients on the units without jeopardizing the health and safety of the providers or the patients. Next slide. So we really, this slide is repetitive, I apologize, but we really, we changed our focus to more educational things like overdose awareness, overdose prevention, aftercare planning. And, we really were just focused on keeping these patients alive and giving them what they really needed, especially in our ATS level of care, where it turns over so quickly. And as Jessica mentioned, you know, people are lonely. When they were leaving detox and going back home, we wanted to make sure that they took with them that education on how to prevent an overdose. Next slide, please. So probably about 2 to 3 weeks after the pandemic really hit, we sat down and we really realized that we were missing a pretty significant subset of patients that we were turning away before they came in the door. So turning away at the trailer or at the tent because they had a fever or because they were exposed or because they had a pending test back then. And we really felt like, you know, if there's a way we can do this, you know, it's our responsibility to provide this service to this population that really needs these services. And so on April 24th, with the help of the BSAS, the Bureau of Substance Addiction Services, we were able to launch this unit. And this is the walking bridge that I'll talk about in one moment. But this is the area that our staff donned their PPE, and you can see there's a mirror so they could watch themselves and make sure they were following the procedures. And at the opposite end of that walkway was the entrance to the actual unit. And so the goal of the next slide, please. The goal of this unit was to provide all levels of care. We offered it was one unit, 15 beds, but you could be needing ATS level of care, CSS level of care, or residential level of care. And, you know, you could be admitted onto this unit. The unit actually staffed 4 people, 2 nurses and 2 recovery specialists, and all clinical work was completed via a tablet that each patient was given upon their admission to this program. Just of note, we didn't force staff to work on this unit. We asked for volunteers for them to work, and you know, we were able to fill both schedules. We did pay a $5 an hour stipend to folks who volunteered to work on this unit. Next slide, please. So this is the best picture that I had of the front of this building, but you can see that there's really 2 wings to it. And if you look closely under the flag, you can see that walking bridge that I referred to. So the COVID unit was the left-hand side, and staff entered through this entrance under the flag, and they entered the bridge, and that's where they donned the PPE. And then, you know, the other side of the building to the left exited to the outside, and we created an area where they could then remove the PPE and dispose of it. But once we found the unit and we knew that we had this unit that would work, that we could keep, quote unquote, a clean and a soiled side to it, we were challenged with, you know, where will staff take their breaks? Where will staff use the facilities and take showers before and after they got done working on this unit? Next slide, please. So we really had to get creative. And so this is a back parking lot behind the unit. And the unit on the right was a shower and bathroom unit, 3 units, as you can see. And the unit on the left was our break room. And so the unit on the right, we actually rented, and many of you may know that these units were very expensive back then and hard to find. So we made the decision to purchase a unit similar to this, so we would really have it for future planning. And then, you know, a staff person was nice enough to donate their pop-up for the break room. And she, several months later, ended up donating that to the organization. So it's still there, and the staff for this unit still utilize it to take their breaks. Next slide, please. So just a case study. Gabe was a middle-aged man that came to us. He had completed a detox with another agency and came into our CSS program on August 28th. On September 10th, we did some screening testing of clients, and he tested positive. He was transferred to the COVID unit on September 10th. He 10 days later tested negative for COVID and, cleared the unit and was non-symptomatic and transferred back to our CSS level of care. And then on 9/22, he was transferred to our long-term treatment program where he continues to be today. And so, hopefully we'll retain him in residential for 6 to 9 months, and then, we'll move him on to one of our outpatient programs. But this is a case of, what we were able to do, and that we didn't have to send this gentleman to the hospital. We didn't have to clog up the ER. We were able to just transfer him to another building and, treat him and manage his symptoms. He had mild symptoms. He didn't have extreme symptoms of the COVID-19. Next slide, please. So, how did we recognize staff work during this time? We provided all staff with, I mentioned that we provided the COVID unit with $5 an hour, but we provided all staff with a $2. A lot of people refer to it as hazard pay. We ordered lunches for these staff. A lot of times there were different organizations that were donating these. We had several of these come through and donate lunches. So we had somebody that really researched that and reached out to those organizations when we could. And then we just, we got these t-shirts this gentleman here is wearing in this slide, that it really just was uplifting. And some of the, these are really low cost things that the staff were able to feel appreciated. And we really were able to maintain a good level of staffing throughout. And we continue to be able to throughout this pandemic. And I think it's because of the recognition we've given the clients. So next slide, please. So telehealth, it's challenging. It's not easy. It's different. We have many generations of people that work. Some are great with, with technology, and some aren't so great. So we had a really good response from, some of our younger clinicians, but some people who have been with us a while and are used to that face-to-face contact really took them some time to adjust to this change. Next slide, please. So again, I think, immediate access to care during COVID-19 is important in making sure we're educating people on the overdose awareness. And when you're going back home and you have a tendency to isolate, really talking about that with clients before they're leaving us. We certainly have seen several, clients come back for treatment, and we tell them, call us, come back if you're feeling like you need a safe place to be. Next slide, please. So from a reimbursement perspective, you may know that to access insurance, much of our population has to check in, make sure that you've picked a primary care physician, make sure you've updated your address, you get mail and you're asked for information. And COVID-19 really, highlighted that this is a broken system. And so, people would lose their insurance mid-stay. And so, it's always important, but one of really, especially during COVID, to run those every day so that we knew we needed to change them to, a DPH bed if we needed to. We have DPH funding at all these levels of care. I think, telehealth is challenging. You have to unlock those codes in outpatient, and you got to make sure that people are reimbursing. I think, most of the payers were really forced to get on board with this pretty quickly. And I think we've been talking about telehealth for quite some time, but I think COVID really forced us over that line that we couldn't seem to get over there for a bit. The list, is there one more slide, Kevin? So the list of lessons learned from this pandemic is extensive. And, I think once we've all had a chance to catch our breaths, we can learn a lot from each other. I think we have a real opportunity as a provider community to learn a lot from each other and how we all responded. Telehealth is here to stay and provide a flexibility in the ability to meet clients, where they're at is going to become more important. I think, as I mentioned early, one of my lessons learned is really, PPE and making sure you have a supply of that on hand that you can turn to. And I don't know if we, have a trailer that just is stocked, or, Spectrum sometimes has storage challenges, but, finding a way to make sure we have a place. Technological preparedness is also something, that we have to be better at, and we have room to improve. And I think just the ability to think outside the box. I mean, if something like this is to happen again, we'll certainly be able to turn to the plans and the things that we did as a response to COVID-19, and learn from our experience.
Thank you so much, Kristen, for sharing Spectrum's experience. I'd like to hand it now over to Dr. Sarah Bagley.
Great. Thanks so much, Kevin. Thank you so much for the invitation to be here sort of virtually tonight, and to the other speakers too, because I think that you're going to hear that I'm going to be talking about some of the same themes, I think picking up on what's been discussed so far, which is hopeful, because maybe that means there are some things that we're learning that we can sort of take going forward to sort of make sure that we continue to serve our patients and families. So I actually don't have slides tonight, but I do have notes, so I will talk through, and then we'll be able to answer questions at the end. So as noted in the beginning, I'm a primary care provider, an addiction specialist at BMC. And so tonight, what I'm going to do is talk a little bit about sort of how our outpatient model of care has changed during these last months that we've been impacted by COVID. I specifically spend most of my time in the outpatient world taking care of adolescents and young adults. So some of the experiences that I've had are really specific to that population, but also do take care of older adults as well, so can sort of speak to their experiences as well, I think. So to get started, what I wanted to do is sort of set the stage and explain the way our outpatient programs worked and functioned before COVID. So we all have I work in an outpatient program. We're based in primary care. It's a nurse care manager model. It's sometimes described as a collaborative care model, sometimes even the Massachusetts model. What it really means is that that prescribers, so MDs, NPs, NPAs, partner with nurse care managers who have specialty in addiction care to provide outpatient care, mainly focused on patients with opioid and alcohol use disorders. And these are patients who receive their addiction care and their primary care in an integrated way. And prior to COVID, all of the care that we provided was in person. Patients are often seen by their prescribers, at least every 2 to 3 months, and then by the nurse care managers more frequently. And I will sort of point out that all of our outpatient care also included urine drug testing. A main component of our outpatient care is medication treatment. So with medications like buprenorphine or naltrexone, which are FDA approved to treat opioid use disorder, naltrexone's for alcohol use disorder as well. And in the program that I run for adolescents and young adults, we also have social workers who provide therapy. And then also we have recovery coaches as well, in addition to our nurse. Because I think, as you've sort of heard already tonight, that patients require, a holistic sort of wraparound care. So once March hit, as you've heard, so many things changed. And it's interesting because I think we've talked a little bit tonight about telemedicine, and it had always been, there were some studies really suggesting that it was possible to provide telemedicine addiction care, but it was something that was not reimbursed. And there was always a lot of resistance. I work at BMC, it's a big hospital. It was something that we always wanted to do, and we just were not able to pull it off. However, once COVID hit, things changed. And I think that as we slowly saw that our ambulatory or outpatient clinical sites were being shut down, and patients were really being discouraged from coming in unless they had a really urgent reason to be seen in person, all of a sudden there was this possibility where we could provide telehealth. That was really exciting. I think then the question was, how are we going to be able to do this for our patients who have substance use disorder or opioid use disorder? Because there were still going to be restrictions in terms of being able to prescribe medications like buprenorphine without in-person visits. So fortunately in March, a couple of things happened. One was that CMS agreed to pay for telemedicine during COVID. And then at the end of March, the acting DEA administrator also declared that telemedicine, we could use telemedicine and we could initiate treatment with buprenorphine. And so that was really important. At first, there were restrictions and it had to be done with video, but then they loosened restrictions, loosened the regulations further, and were able to sort of start patients with on treatment over the phone without video capabilities. I'll highlight, and some people may say like, well, is that concerning? Sort of what's the quality there? I think that the issue is that the video, requiring video capabilities is sort of an extra bar that, especially for our patients who sort of don't have access to smartphones or computers or iPads or reliable internet, that it would really be sort of discriminatory and they wouldn't be able to access treatment in a fair way. So that was a really important part of the changes. So then things really changed. So, all of a sudden we were seeing our patients virtually. I was doing most of my visits, I was still doing most of my visits over the video. And then sometimes over the phone. That also meant that sort of new referrals, we were starting medication treatment virtually as well. It meant that we stopped doing urine drug testing because we felt like the risk of asking patients to come into the hospital setting really outweighed the benefits of sort of doing the close follow-up, both sort of me combined with our nurse, we felt like we could sort of get a sense of what was going on with our patients. And so that was all really exciting. And I think that, for patients who had always had issues with transportation, even though we try to make it easier, or had, also have co-occurring mental health disorders that sometimes sometimes are barriers, just sort of making appointments or being able to keep track of schedule. It can be hard for some of the patients we see. It was really exciting that we were able to be more flexible with them. I guess I want to point out too that I do take care of patients who are on methadone, and although I don't work at a methadone program, the regulations were also loosened, and so the methadone treatment became more flexible. Patients were able to take methadone up to 28 days home, who had not previously been able to do that. I'm happy to answer sort of more questions about that in the Q&A. And so, I think especially it's still now, but in the beginning, it was really exciting to think about sort of how could we make outpatient care more accessible for patients and more patient-centered. And so things really changed. I think that one thing that came up pretty early on was that there are still going to be times that we want to see patients because we may want to check labs. We were starting to see some increases in HIV. We treat hepatitis C, and so we need sort of labs to be able to do that. We do other primary care that sometimes requires in-person visits. But adding in this flexibility of telemedicine was really important, and just allows things to again to be more patient-centered. specifically with adolescents and young adults, in the beginning, we saw a real increase in referrals initially, I think sort of mirroring what you've heard already, that sort of from the beginning, we saw this impact on substance use and mental health. And we saw, especially with the introduction of telemedicine, a significant improvement in adherence to behavioral health appointments with our social workers, and more desire from parents as well to be more involved and have more parent guidance appointments with other members of our team. And so, so these first few months of the pandemic, things really dramatically changed the kind of care, the way that we were providing care for patients, in some really exciting ways. I think though now, even though we are still very much in it, I think that as time goes on, we have at points been able to stop and catch our breath a little bit and sort of say, like, what is going on? What really has been the impact on people's substance use, on their mental health? What do we know? What have we learned? And what do we need to do to continue to sort of innovate so that we meet the needs of our patients? So, I think, as you've heard, that there's the data to support this, but that we've really seen, especially I would say in recent months, a real increase in anxiety and relapse in our patients. So I think, some of the quotes that you heard earlier, I'm sort of thinking of my patients right now, and some of my patients who have been stable for many years, and I'm thinking of a patient who has been stable for 5 years and had a recent relapse. And I think that the combination of the isolation and the anxiety, I think is directly related. I think that, we also hear from patients who are parents in recovery, and, they are not able to necessarily sort of access the usual networks of people who support them in their recovery. And that is, they're increasingly stressed out. And so even some of my patients who have certainly not relapsed, but their anxiety is so much higher than it was a year ago. And so I certainly then always worry that may lead to relapse. I think the other thing that has happened in the last month or two is that as we've been able to see some patients in person, more patients have been asking to come in person. I spoke to a patient last week and I said, we could keep doing this on the phone, that's okay. But that I would be happy to see them. And I think there is this sort of desire for human contact and to just be able to sit with each other and talk. And I think that's true for patients. And I would say as a provider, like that's sort of what fills my cup too. And I'm also missing that. I think the other sort of important theme that has really emerged, I think, especially in these last couple of months, is the impact of the increased stress on families and social networks of people who have substance use disorder. So, which is something, again, that has been sort of highlighted tonight. I think that, I'm thinking about a couple of families who are at home with their adult children who are in different sort of stages of their drug use. And it is really hard on them as well. They're experiencing sort of all of the stresses of not being able to necessarily go into work, of sort of everything and they are also unbelievably concerned about their children who are, still using drugs, and they are feeling like they are not able to access the kind of supports that they were able to a year ago. So I think it's really important. We've talked about families tonight, but we always need to include families because they are really impacted by all of this as well and really need our support too. So, I think that, what do we know? We know it's November. We know that, from there was a brief that came out from the American Medical Association at the end of October that 40 states are seeing an increase in overdose deaths, and those are related to fentanyl. As was, that increase in fentanyl use was sort of highlighted earlier on. I think that in response to that, I think it's going to be really important that we continue to put pressure on our legislatures to sort of keep the regulations that have allowed increased access, like telemedicine, to be possible. That we sort of really need some of those changes to be permanent, so that we're able to continue to allow access to treatment be feasible for everyone. I think, though, that as we do that, we need to think about what's the potential for exacerbating disparities or inequities. So I talked a little bit about this, but sort of access to phones or videos or internet is sort of not possible for all patients. We had a patient last week who really wants to engage in therapy, but lives in a house where he just does not have any space to himself. And so literally cannot sit and do psychotherapy, even though it's what he really wants to do. And so what are we going to do about that? And how are we going to think about, you've heard about some pretty creative ways tonight to sort of think outside the box. And I think that we really need to continue to do that, because it's going to be patients who are sort of at the margins who may be left out as some of these innovations continue to be promoted. Again, which I think in general is really great. We just sort of really have to think about what is the impact on all. And, I think the other thing that I just would want to sort of highlight before I end is just that the teams of people who are taking care of these patients also need support, whether or not they're doing it in person or remotely. I think that sort of this is work that is so rewarding and is such a gift to be able to do. Like, I just feel so fortunate to be able to do the work that I do. And I think, though, that what has sustained me in doing this work is sort of my relationships with my colleagues and the support that I get from my colleagues and the way that we work together as a team to take care of our patients. And I think that we're isolated too from each other. And so sort of how do we think about supporting teams and making sure that we're checking in with each other as we go along too is going to be important, because it looks like for now anyway, we have some months ahead of us before this is things start to bend back towards normal. And so if we're going to continue to do this good work and sort of taking care of people affected by substance use, we need to ensure that those involved in that work are also supported and getting all the care that they may need as well. Thanks so much.
Thank you so much, Sarah. I'd like to now hand it over to our final presenter for the evening, Mr. Warren Nickley, who, as I noted in the beginning, is the director of a New Way Recovery Center, which is part of Bay State Community Services. He'll be speaking this evening on sustaining recovery and mutual support during COVID-19, a recovery coach's role. Warren.
Hi, thanks, Kevin. Appreciate it. I've heard everyone talking. Everyone's covered quite a things, and it's great that that's where the mutual support comes in. It's like between the emergency room and Spectrum and all those different areas. One of the things, as everyone has said, is COVID obviously put a very large damper on all of the work that we were doing way back when. But one of the things that I really want to highlight is the recovery coach program that we have had and still have through the Recovery Center and through Bay State. It's the HEART team. And one of the things I really want to highlight about that is that they, from the beginning of the pandemic back in March, they were in the emergency room 24 hours a day, 7 days a week. One of the things that we talked about with the coaches was having them do it by phone, by telehealth. And they refused to do it that way. They wanted to go in. We only had one coach who chose not to go in due to, some underlying medical conditions of her own. But the coaches went into the emergency room every single day and every single night, 24 hours a day, 7 days a week, and they met with the recoveries in there. And the work that in the whole idea of a recovery coach, for those who don't understand the role of a recovery coach is somebody who has been in that bed. They understand, they are somebody who has struggled with substance abuse, substance addiction throughout their lives. And they've been there. Many of them have overdosed and have been in those emergency, beds. And so they're able to play that role. And, because a lot of times you'll hear someone say, well, if you don't get where I'm coming from, then you're not going to be able to help me. And in this particular case, they can. And they also I think they take a large burden off of the emergency room itself too. They're able to come in and try to place somebody in a bed, you know, in any of the programs throughout Massachusetts. And it's really, I can't say enough about the work that they've done and continue to do. The heart program itself through Bay State, through the Recovery Center, unfortunately has changed. We still have it, but now we no longer cover 24 hours a day. We now only cover 12 hours a day. We cover from 8 a.m. to 8 p.m. in 2 of the emergency rooms. And as many of you probably know, Quincy Hospital closed their emergency room on November 1st. So now we continue to cover South Shore Hospital and Weymouth and Carnegie Hospital in Dorchester. So, and they still go in and they still do that work. And I think the pieces to that are when they go into the emergency room, they're able to, you know, help guide that person because the recovery story. So as they're recovering, you know, the way they guide them is, you know, again, as I said, you know, sort of being that person, have been in that bed and have done that. You may get somebody who has never been in there before or who has relapsed continuously and they don't know what to do. And the recovery coach comes in and just says, hey, listen, you know, what is it you want? What is it that we can do for you? And if they're just not sure, they can give them many, many ideas. One of the big things that we see is a lot of people come in and they want to do medically assisted treatment. You know, not a lot, you know, and they will help them to get that. They will help them to sort of, you know, go where they need to do. They will make those phone calls. They'll help out the emergency room staff to, you know, to get those phone calls made as well. I mean, they just step in and they take the role of so many different people. And it's just, I mean, I've seen them at work for the last 5 years and I just can't say enough about them. I just think what they offer is just an amazing thing. And I know many of you, you know, have seen them or worked with them or have talked to them over the years. And, you know, it's just a great thing. So the other part of this too is that, you know, the recovery centers, there's 26 of them in the state of Massachusetts. I believe almost all of them are open. Unfortunately, I don't know which ones aren't. I think some are still so brand new that they're not quite there yet. You know, because they have to, you know, get ready. Because originally, you know, when you opened up a recovery center, you just opened up a recovery center, you bought some furniture, you kind of got the literature that you needed. Now, of course, you need to get your PPE and, you know, you need to get all those different things. So it's just opening a recovery center isn't quite anything like it used to be. We at a New Way Recovery Center in Quincy, we were closed for about 2 months, maybe a month and a half. And we still worked from home. All of the staff, including myself, we did Zoom meetings. We had them set up from our own homes. We were able to, you know, engage folks from their homes into all of our different, we even held our community meetings in there. We held as many 12-step meetings. We continued to have a SMART meeting, and we, you know, we covered many of the different aspects of recovery itself. As we slowly opened, and again, as, you know, I think there was, you know, as folks were saying, you know, to sort of open, it was a very different, I was just amazed at what we had to do to open up our doors again, you know, like going out and buying PPEs and, you know, dealing with China and dealing with all of this crazy stuff that we had to deal with, but we were able to get it done. And, you know, we're open now. We've been open. At the beginning, we were challenged with the Bureau of Substance Addiction Services had said to us, we could only have 10 people in the building, and we worked with that. We had 10 people. So if 10 people came in for a group and there's 4 staff in the building, I would just have the 4 staff leave and, you know, go shopping for an hour or something and just to be able to do that. And so we were able to work on that on a sort of a smaller basis. But again, we still continued to keep the Zoom meetings going, you know, so it was Zoom and it was live at the same time. The other part of that was eventually we were able to up our numbers through the state. And now we're allowed to have 25 people in our recovery center. Our recovery center is a pretty good sized space in Quincy. So we're able to have a few more people than most recovery centers are able to have. And we're pretty much back to full schedule. There's a couple of meetings that haven't happened. You know, some people are still a little leery about coming in, but we're still offering that live and Zoom. So they're still offered for all of the meetings that we have. We're able to Zoom people in, and it's working, you know, and I mean, that's the important part, is that it is working. And, you know, I think people really do appreciate the fact that they can come up, because the fear is there. You know, we deal with all age groups from 18 up, and, you know, a lot of people are just, you know, again, they just don't want to come out into a center where, you know, they just don't know. And, you know, to come into our center, this has never happened to us before. Our doors were always open. Now our doors are locked. You just have to ring the doorbell to come in. You know, it works. So first I thought it was always going to be a block for it, but it's not. And when you come in, you know, there's a PPE station as you walk in our front door, and there's masks there and sanitizers and all of that stuff. And we have shields if need be, if folks want that. And people are able to, you know, come in and get what they need. They come in and, you know, then they're welcome into the center. You know, we do take names and, you know, phone numbers or email addresses in case we ever have a positive from somebody that's been in the center. But we've been very, very lucky. Again, you know, people are, you know, the staffing at the recovery center is just, you know, they're amazing. You know, they're very aware of what's going on. So when you're on the floor, you have to have a mask at all times. Even when you're 6 feet, you know, when you're 6 feet apart in a group or in a meeting, we ask that you keep the mask on to the best of your ability. If you want to speak, you know, we ask it, you know, you can remove it, but, you know, it's really you know, it's really fear of, you know, we just don't want to, you know, we want to make everybody feel comfortable, I guess is where I'm trying to go with that. So, but again, you know, that's really the, you know, the support, the groups that we have, like, I know folks are saying, you know, families are struggling at the recovery center. We do have some groups. We have Learn to Cope, which I know some of you may be familiar with. It's a support group for parents. Currently, they're still just doing it on Zoom. They are not coming in live, but we can get folks set up with that. Coming back tomorrow night, which is a group that, you know, we're kind of glad that they're coming back and they're coming back live. It's called The Sun Will Rise, and it's run by a woman, Robin Houston Bean, who lost her son about 5 years ago. And it's a grief group for folks, for parents or you know, any family member that have lost someone due to a substance addiction overdose. It's a great group, and that's coming back live. And, you know, it's a support that's really needed, because I think Dr. Bagley had said, like, the families themselves are really struggling. And, you know, sometimes they feel like there's no support out there for them. And there is. You just have to reach out to, like, other recovery centers in your area. Like, we're in Quincy. And again, Massachusetts is pretty covered right now with recovery centers. And, you know, you just have to kind of look them up, or you can always reach out to us and we can certainly point you in the right direction. You know, and then again, we're offering all sorts of, you know, different aspects of recovery. We have SMART meetings, we have 12-step meetings, we have all kinds of different stuff. So I think that's really the mutual, you know, sort of the supporting that we're able to give it. But again, going back to the recovery coach's role, and I'm sorry that I keep bouncing back and forth, but the recovery coach role, that peer-to-peer model, it works, you know, and again, those recovery coaches are just an amazing group of folks. So, and now the new thing that we're offering at Bay State is, so if you go in and you see the recovery coach, the wraparound service was sort of there, but it wasn't at the beginning, because you would see the coach, you would see the recovery in the emergency room. And so, you know, we would move them on to, you know, a program technically, or sometimes they would just leave. Again, we weren't a detox service, but we certainly, whatever the need for that recovery is the need that we try to meet to the best of our ability. Now we have a new program where when the recovery coach goes in for that 12-hour period from the 8 to 8, we have programs now at Bay State where we can sort of bring that wraparound service. And then we have recovery coaches who work strictly out of there. They don't come into the emergency room. The emergency room recovery coach would transfer them over to the recovery coach in the building. I know it sounds silly, but one recovery coach covers the emergency room, then the other one comes in and they, you know, bring them into the, you know, fuller services. Also counseling services, and we have a nurse practitioner on staff, and we have a nurse on staff, just sort of follow through with all those different roles. So it's a program that's growing, and it's very exciting. It's probably, I think we're in a second month for this new program, and you know, it's doing well. I'm really very surprised, because I know as many people on this call know that when you start a new program, it takes a very long time for it to sort of become established. And this has become established very quickly. And again, I think a lot of it has to do with the fact that we're in the middle of a pandemic. You know, that's pretty much all I have to say on all of this. You know, obviously, hopefully we can answer some questions for folks. And again, I really do appreciate you all, you know, having this tonight. Thank you.
Thank you so much, Warren, for sharing about your and your center's experiences and also the role of the recovery coach. At this point, we're going to open it up for questions and answers that can occur actually through the chat box initially. And then in the last 10 or so minutes of our time together, there will be some opportunity to for anyone who has a question that wishes to speak it, for a handful of folks to actually speak their question to the panelists. If anyone has questions that they're have for the panelists, feel free to type them in the chat box. And Kyla, who is assisting me tonight, will be sending me these questions that I can then pass on to the panelists. So the first question I have is that I've received actually is for Jessica. Jessica, in your presentation, you described that the highest overdose percentage from the sample that you collected was in the southeast coast. And one of the viewers here was curious if you have any thoughts about why that was the case.
So we used the census regions to sort of compare, but there wasn't quite, we had some states where we had more respondents because of our chapters are more active. So, I sort of shared this with that caveat, but the number for that whole region was much higher because of West Virginia.
Okay.
So we had quite a few overdoses reported, and we have a fairly active chapter and network of families and patients in West Virginia. So followed by Florida in that region, but it was really a larger amount from West Virginia, Texas, California, Massachusetts, and New Hampshire.
Excellent. We have a couple of more questions, Jessica, that were prompted by your presentation. So I'll just continue in succession. The next question is, in your presentation, it was observed that 4 states didn't respond to the survey. And how might that have affected your results? And do you have any thoughts about why they chose not to participate?
I don't have a very active chapter, for example, in Wyoming. And we also had a very short recruitment window of only about 10 to 14 days. So, having 1,000 patients and families that are willing to participate in research in 10 days, we were happy with the results. I don't think that having just 4 states not participate, largely because of, in one example, my mom on the ground was on vacation. So, sometimes it just happens on how things are scheduled. I don't think it skews our results. I think with 1,000 responses, we can really have some important takeaways that I think likely apply to the states we weren't able to connect with. We were able to to sort of shore up some of our linkages. We do have folks on the ground in all 50 states and hope to have an even larger sample. That's a bit more racially diverse next time we have a survey that goes out as well.
Thank you. And one final question before I move on to another panelist. Jessica, someone is interested to hear, what would be your top priority for change in the event of a significant resurgence, which unfortunately we might be seeing right now?
I really don't want recovery meetings shut down ever again, and if we can avoid it. I think that we've spoken to a few governor's offices about this, though we didn't specifically shut down recovery support. They were technically listed as essential services along with treatment, addiction treatment in many states. The locations that we hold these meetings were shut down, churches and schools and community centers. So by proxy, we sort of cut off kind of the lifeblood or the safety net. I really think of it as that there's a safety net that exists, and so many more people are accessing the safety net to support their management of this chronic health condition than we realize, right? Our latest survey shows that the majority of our network of patients are accessing support services multiple times per week, or they were before the pandemic. So when you shut those off, I don't think that we have thought through sort of the impact of that. And we're worried, of course, we're very worried about COVID-19 and transmission and keeping people safe. But addiction is also life-threatening, particularly when you have a severe health condition that you don't have access to some of the key pieces that keep you healthy, keep you well, and keep you connected. So I think if we should hit another lockdown again, I think not over relying on Zoom only, figuring out If I can go to a yoga class with 4 people in it and 9 feet in between me and the next person stretching, how can we get creative to keep people safe, but keep them connected to their safety net if they have a substance use disorder and they require certain services for their support?
Thank you. This next question is for Kristen. The person says, it was amazing how quickly you and Spectrum responded to provide care for the population with COVID. And in your presentation, you describe various levels of care that are offered through Spectrum. This question comes from a nurse who does not have previous backgrounds in addictions, and so is curious if you might be able to elaborate a little more on the levels of care.
Sure. So ATS, detoxification, ATS stands for acute treatment services. That's really the entryway for many people. You know, we staff nurses 24 hours a day. There's a ratio we need to meet, and they need medication for their withdrawal symptoms for alcohol, opioids. You know, certainly we're seeing a lot of fentanyl at this point as well, I want to highlight. And that's typically a 3 to 7 day stay, and it's really individualized based on symptoms. CSS is clinical stabilization services, and maybe you might know this as a step down. A lot of people refer to it as a step down program, and there was a significant treatment gap many years ago. You know, what do we do with patients after detox? And, you know, CSS was really a godsend back then. And so, you know, just really quick, back in November, we doubled our CSS capacity and we filled the beds in a day and a half. You know, so it's a level of care that many people seek. And, you know, most of the time people still might not be feeling well, but it's clinically intensive. There's more groups, there's more counseling, there's more really talking about what's your next step in helping them to find, whether it be a residential program, sober housing, etc. And then residential program, Spectrum has really changed its definition. You know, many years ago, it was, you know, 18 months to 2 years. It was a therapeutic community. You know, but we recognize that there are a lot of people that can't just, you know, take a year off from their families or their obligations. And so really it's so individualized. Someone could be there for 60 days. And we also have a young adult program for males for ages 18 to 24. And they can be in treatment in that particular program for up to 18 months. And that's, you know, we that level of care allows you to find a job, start making some level of income, and so it's really that next step before you go home or go back into an apartment or live on your own.
Thank you so much, Kristen. This next question is for Sarah, and after Sarah shares, any other of the panelists who have thoughts about it may chime in. The viewer asks, do you think that telemedicine restrictions will continue to be lifted? So this change in policy will continue once the epidemic diminishes. And I'm mindful that you have some, I'm sure have some thoughts on this, and possibly other panelists as well.
Yeah, sure. You know, I think that, I guess I'm hopeful that yes, I think that, you know, a lot of work went into allowing telemedicine to sort of be possible, and sort of to create also, like, you know, I work in this big hospital system, and all of a sudden the infrastructure was put into place so that we can bill for these services, which is something, right, that we couldn't do before. And so I think that it's been created for us. So, and I think that there is tremendous support for it too, I think, but from sort of providers, from families, from patients. And so I think that my hope would be yes. I think that we'll have to sort of see as things sort of pan out in terms of like what the reimbursement actually looks like and sort of whether or not it's sustainable and whether or not there are sort of mixed models. But we've certainly found that it's feasible. And so, I think, so my hope would be, yes. I think, one thing that I will also just sort of raise, there's a question, someone privately chatted me this, but I think there's this question, start to get to this person's question is like, sort of like, how do you know if someone's doing okay? I was sort of saying that we don't do urine drug testing. So if all of this switches to sort of telemedicine, like, how are we monitoring people? Do we sort of know what's going on? I will say, I mean, I all I can do is speak to sort of my program's experience, but we, like our patients, we sort of say that our philosophy is that we offer treatment, but we're a harm reduction, or like we offer harm reduction, and that you don't have to want treatment to come see us. And so our patients call us when they're struggling, and they call us when they're using, they call us when they've relapsed, so the urine drug test has always been like a tool that we sort of monitor, and it's a part of sort of how we make assessments. But we've been sort of amazed at how people have really kept in touch with us and helped us navigate to places like Spectrum, to be honest. Like they relapse, they need help getting into detox, so they call us, and they're sort of, so I think that has to do with sort of creating relationships and people sort of knowing that you're there to help them get the support that they need.
Thank you. Warren, there's a couple questions for you. Given how meaningful the recovery coach relationship is, this viewer was curious if you or Bay State are doing any research on the outcomes of the services. And if not, the viewer thinks you should be, with excitement.
So we have done a little bit. It's actually with the excitement. It's something we're doing now more with the new program, is seeing, we've always had outcomes from our services that we always did have the outcomes. I guess I'm just trying to think of the best way to answer this. It's the outcomes were always there. I mean, the success is it's around 25%. Again, we see folks, there's probably right now a handful, I'd say about 10, maybe 12, that we see almost every single Monday. We know we can count on seeing them at Kearney or South Shore Hospital. And, it's really, it's just sort of it's a hard thing to track, but we are definitely have a different system now that we are tracking. So with your excitement, yay.
Thank you.
You're welcome.
And also, another question. You mentioned that it sounds like your recovery centers meetings, many of them are hybrid. So it allows people to be in person, within the 25 limit, and also folks to join, I'm imagining, through Zoom.
Mm-hmm. Yes.
And so the question was for people to get involved with that center in those meetings. Is there an intake process to get involved with the center, or is just information about all of this just available online?
So recovery centers are all non-clinical. So you can reach out to us. We do have a Facebook page. It's a New Way Recovery Center. You can reach out to us, and I can certainly post the phone number on chat if you would like. And you can certainly reach out to us, and we can send you. We have a monthly calendar, and on that calendar lists everything that we do. And the groups that are hybrid and live are in the Zoom. The passcode and all of that is right on our calendar. You can certainly call the center, and we would email it to you or something. But you can certainly do that. And if you check our Facebook page every day, we do post everything that is happening on that day. So, but I will definitely, on the chat, I will put in our phone number, and folks can reach out to us.
Excellent. And,
Sure.
and the last follow-up question is that
Sure.
have you or other members of the recovery center had any conversations or thoughts about whether or not the hybrid model might be something that you continue even after the pandemic is over?
Probably. It's something that works, because if you take the pandemic out of it, which, you know, we would all love to be able to do, and, you know, there are people who want to come to the recovery center who may not, you know, mobility issues, or they just, you know, they don't want to be in groups of people. So it is certainly something we have talked about looking at, but right now it's in place. And do I see it going away anytime soon? Absolutely not. But yeah, it's certainly something to look at once this pandemic has gone away. And yeah, I think we probably will, but, you know, but reach out to it, you know, always reach out to us. We're always available, and we don't always just have meetings. Like, we have fun stuff too. I mean, meetings, I guess, can be fun, but we do have, you know, like they're talking about movie nights and that kind of stuff. And we do art therapy, and we have many different things. And, you know, I know relapse has come up a lot here tonight, and it's very real. We do have a relapse group that it's been a very well attended group. So you know, it's been really good too. So yep. But I will post our phone number on the chat.
Thanks so much.
Sure.
And this is a question that any panelists can feel free to chime in about, and it is coming from a participant who sounds like they have some lived experience. So the question is, you know, when you have a relative who gets care via the telephone, how do you include appointed family members in the visit if they live out of state? This particular person notes that she's been told by the provider or the center that her sibling gets care at that they do not offer conference call options, so that to include her in his care, despite the fact that she has power of attorney with him. And I don't know if any of the panelists have encountered a similar situation. If so, how you've managed it.
I guess I would say I don't have a perfect, this has not specifically come up. That sounds very specific to that center. I think that my experience with programs is that if you, I don't know exactly how the power of attorney affects it, but if you have a release that sort of allows a family member to be included, that they should be included, and that the sort of where someone is in terms of in state or out of state shouldn't matter. It's really that sort of permission to talk. Mm-hmm. That's what's important. So that sounds to me very specific to that addiction treatment center.
Yeah, thank you. You know, oh, Jessica, did you have a comment?
So the other thing that we've done a couple things to sort of backfill or try with this safety net this year. And one of them is we released a guide called Navigating Addiction and Treatment, a guide for families. So we do have some information. There's not a ton on specific cases like this, but it's a free resource that we've made available. We worked with addiction specialists and addiction psychiatrists in pulling this together as a family member impacted by addiction. It's been an item on my wish list for many, many years to have something that helps families navigate such a complicated illness. And I'm happy to share a link or share it with you, Kevin, so people can access that. We need to make information for families much simpler for individuals to access. And just sort of to bring it together, the reason I got involved in this field and do this work is because I lost my parents to heroin use disorder. So, you know, when I was 20 and my father was looking for help and he passed away soon after, I even worked in the field, and it was difficult for me to find the right answers and find the right provider and make sense of all this. So we really try hard to simplify that and make sure that our families can access people to ask questions. We're happy to connect with you and get you connected to perhaps some folks in the state that you're having issues with, to see if we can support you, because that's why we're here.
Thank you so much. There's another question for any panelist. A number of you talked about thinking outside the box. And as you started to think outside the box on how to do things differently during the pandemic, how challenging was it to get the bureaucracies, both inside your systems and outside, to go along with you?
So I can speak to this a little bit. I think the Bureau of Substance Addiction Services was really looking for unique ways and for people to think outside the box and come up with proposals on how to fill the gaps during the pandemic. And I think, initially, internally, maybe a few people said, what do you guys want to do? But, eventually, after understanding our perspective and really seeing the numbers that of people that we were turning away, they were on board pretty quickly. So for this particular specialty unit, we really didn't face any, we didn't meet any gaps. I mean, we got it open within 30 days of coming up with the idea, which is just amazing. And it's really a testament to, people working together to meet a need.
Excellent. So this next question is to any panelists. In the age of COVID-19 and telehealth can pose difficulties in maintaining boundaries with clients and knowing when to clock out for the day. Can you speak, any of you, a little bit about how you have engaged in self-care and give any tips or suggestions to us as to how to maintain healthy boundaries and be able to spend time on ourselves as well? Thanks.
I can speak a little on that for the team at the Recovery Center. And we, we really encourage self-care. It's very important. Like for myself, I mean, I get out and go to the gym and, get out, walk in, run and all that. But we offer yoga once a week, and the staff is welcome to join the yoga with the peers. And we offer, like, go out for a walk, take care of yourself. We're really good with doing that. We're working a little bit harder on the coaches to get them with self-care, because they sort of seem a little more selfless, but we really do need to. But if you don't have self-care, you will not survive this. And I think everyone agrees that on the panel. It's very important. And I know for myself, I can speak primarily, it really helps me to get through on a day-to-day basis. But we do encourage it. And staffing is really, really good. And Bay State is great about, pushing folks to take care of themselves. So
we have the same focus for our clinical team, and really when our volunteers, even as well as our staff. We talk about self-care with our patients and caregivers, and I think we need to apply the same expectations to us that are in the field and working as providers or support or whatever the thing is. And some of them is we check in with our whole team daily. Did you get 30 minutes of exercise? Did you get 8 hours of sleep? Did you get sunshine on your face? Did you connect with someone who's positive and healthy for you today? And making sure that it's sort of an expectation within your culture has been really important to making sure that we all stay healthy and taking care of ourselves.
I will sort of step out of my role of moderator and just offer a couple of observations about the self-care and telehealth boundaries. What I've also observed is some of the trickiness with staff having their work co-located in their house. So that it used to be the case that they would go, particularly outpatient providers, would go to a hospital or a clinic and they might be conducting much of their work home, and some are still doing that. And it becomes very tricky because the environment in which you're working gets cued for work, right? So if you're fortunate enough to have a home office, you might be able to contain it and shut the door. But many providers do not have the luxury of having a home office. They're literally conducting their sessions at their kitchen counter with a virtual background, or in their living room with a virtual background. And then those environments become cued for work. And the memories and associations associated with the provision of services are now in the house. And so I do think there's a challenge there in being able to not just shut off the computer, but to like really be relaxed in one's home when there is this sort of blurring of locations. And I know I've seen that amongst providers I work with in various settings. I'm not sure if anyone on the panel has heard similar or experienced similar issues.
Yeah, I mean, I guess I will speak at, so I'm doing a little bit of both, where I'm going into the hospital, but sort of also watching our team doing a lot of their work from home still. And I think that is something that we are, I think, sort of like what's been brought up, sort of trying to be really mindful of, because before this all started, we also had a real emphasis on self-care and making sure that we sort of paid attention to those boundaries, because this work can easily overflow into sort of evenings or weekends, or like beyond sort of the hours that you are being paid to work. And that's because it draws folks who are like really committed and passionate. But sort of as has been mentioned, like you need some time to take for yourself too. Otherwise, it's really hard to keep doing this. And that's harder when we're home. So I think the suggestions that people have about sort of doing the check-ins and sort of taking that time to do whatever you may do that helps you relax is important. And then really creating the culture where that's okay. And if people need a day off, it's okay. And sort of really giving people the space, because it's, it's stressful, or you have parents. I mean, I know some people are parents. I have 3 little kids. We're doing homeschool. I mean, it's just lives are just really busy right now. And there's a lot of stress. And so I think being really kind to each other, to our patients, our families, but to each other is also really, really key.
Thank you. Another question for any panelists, for any of you who work in organizations that have medical residents or student interns of any sort, there's a curiosity about how COVID-19 has impacted your sort of use and engagement partnerships with trainees.
Yeah, so we have at BMC, we're connected to the medical school, and we also have sort of other social work trainees and nursing trainees who are also rotating through. And so sort of at the height of things, it was really impacting things, because we weren't really doing very much outpatient care. And so we were trying to find ways to invite trainees to like do virtual visits with us, which is just hard to do. Not impossible, but it's a little bit hard. It is hard to do. And trying to do that. I think that we found, like, when I spent time on our addiction consult service in the hospital providing inpatient care, and we were really trying to minimize the patients we were seeing to sort of preserve PPE in the hospital. We really were not allowing trainees to sort of be part of that. Medical students were like not allowed to be sort of doing anything sort of clinically. That's changed now. And residents we were trying to sort of minimize contact basically with patients who were COVID positive or sort of under investigation. So we are emerging from that, and sort of trainees are being invited back in. And I feel like we're also starting to hear it's going to there's an anticipation that maybe in the next couple of months, we're going to go back to sort of having things be more restricted for trainees again. And then hopefully maybe by the spring, get back to where we were.
Yes, I agree. I think, certainly interns have taken a brunt of this. We've tried to make efforts to finish up with folks that were with us when the pandemic hit so they could meet their requirements. And so in outpatient, we still do have some interns. However, for inpatient, we have not allowed interns on site. And probably, as Sarah said, won't for quite a while.
This next question sort of regards the topic of isolation. So several of you noted that one of the challenges with COVID-19 has been that folks have been dislocated and disconnected from in-person care, are disconnected from mutual support groups and recovery communities. And there's also a recognition that for many people who go through an addiction and recovery process, that one of the things that many have to work to overcome is isolation and shame. And so it makes me wonder, as we're thinking about, thinking outside of the box and really getting ready and sort of being prepared for the next pandemic, which likely might, my hunch might not be 100 years from now, right? The next public health crisis. What do you think it would take for sort of recovery programming to actually be ready? I think, resources, infrastructure, like what testing, what would it take? That's a huge question, and any of you can take a bite off of it. It's a big elephant, so we won't probably eat it up all at once.
One item that are really interested in is we deployed digital therapeutics during the pandemic. We had about 1,800 patients on during sort of the height of the lockdown, and less on now because they've sort of returned to their services as normal. We didn't develop this technology. We put our own social workers on the platforms that were developed by NIDA. So there was two that we used, HS, which was developed by University of Wisconsin and has sort of built-in technology for relapse prevention, but it really is about pro-social engagement. It's like a Facebook board for 1,800 people who can support you while you're stuck at home and managing your recovery. There's content that there's journaling, appointment reminders, and lots of other content. So we deployed that along with CBT for CBT, developed by Dr. Carroll at Yale. So people can walk through and still access cognitive behavioral therapy during the lockdown. There's 7 modules, and you can tailor those modules for either alcohol use disorder, general substance use disorder, or individuals that are on buprenorphine. So I think when we start to look at all the tools in the toolbox that we can build in building that safety net, from enhanced telehealth, making sure medication access happens more easily, more supportive communities, and then using sort of technology and other services to connect people to care regardless of where they are or what we're going through, pandemics or otherwise. I think I have much hope that we can learn from this and build something better that makes sure that no one falls through the cracks.
Thank you.
I echo Jessica's comments. I think there's so much to learn. And I think, again, once we have the opportunity to take a deep breath, I think, we're all going to take the time to do that.
Excellent. So we have time for 1 or 2 more questions. If anyone else from our virtual audience has any questions, feel free to post them. Well, I have one more question, and maybe I'll do a little disclosure here in a public forum to frame the question. As someone who works at Regis, but also works in a residential recovery center, I found the first few weeks, if not month, of the pandemic to actually be very traumatizing. It was very dislocating. There were many sort of things we were learning about the virus. It seemed policies were sort of getting developed literally on the fly. And now things are much more organized. I'm wondering what sort of supports or resources may have been offered. And Kristen, you spoke a little to this, but what support or resources were offered to staff to help them sort of work through their own experiences of the trauma associated with the pandemic, and also work through their existing experiences of sort of balancing the multiple plates that Sarah was alluding to with 3 children at home and doing homeschool and these sorts of things. So I'm wondering how, if at all, you've seen organizations respond and innovate.
So one of the additional things that I didn't talk about that we did that really, I think, helped with staff, I don't want to paint a picture of unicorns and rainbows. We did have some staff that, left and would just, it was too overwhelming for them to put themselves in our environments every day. One of the things that we did that was really helpful was we actually, Dr. Jeff Baxter is our chief medical officer, and he actually took the time one day to do rounds with us and do question and answers with the staff. And that really was so helpful for them to hear from a physician that, if you did A, B, and C, and, how to wear the PPE, and just answer questions about exposures and risk and things like that. We got an overwhelming response from our staff that said how helpful they found that to be. So that's one thing. And then I think you have to utilize clinical supervision and just supervision in general to really check in with people on a personal level. And we really encouraged our staff and our supervisors and managers to make sure that they were really doing that and allowing that time and supervision for folks to, talk and vent, if you will, about the experiences that they were having. And then, if we felt like, some of our staff needed additional support, then we gave them the resources to get that.
Thank you. Well, I want to thank again our panelists for taking the time out of your busy lives to share with us your expertise and experience and passion and advocacy for recovery, for people connected and touched by addiction and recovery, personally, but also in the family. I want to share my screen to, if I can, multitasking is one of my favorite things to do. I will go back and just want to highlight that if you wish to receive contact hours for the course, we ask that you complete the evaluation form that Kyla just pasted into the chat box. So thank you in advance for doing that. Also, I'll do a quick plug for the addiction training programs at Regis. For any of you who might not have previous experience with addiction recovery but are motivated to pursue training, Regis offers several programs, including a postgraduate transdisciplinary certificate for folks who already have a graduate degree but want to get a respecialization, and master's in nursing programs that also focus on addiction. And lastly, want folks to please mark your calendars. March 10th, 2021, if you can believe it, we will have been involved with COVID-19 lifestyle for a year. There is another President Lecture Series on health that it will occur on the 21st. More information about that panel event, it's going to be on health reform, is going to be available on January 17th on the Regis website. So again, I want to sincerely thank all of our panelists, and to the audience who joined us virtually. This event and so many other things is what gives me hope during these times. So thanks again, and have a wonderful evening.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you very much.